So Joyce, one of the reports from ASCO that caught my attention, and this is thematic with the what to do when you progress on endocrine therapy. We've got all of our chemotherapeutic agents to choose from. Aditya Bardia presented some interesting data on a novel agent, particularly in the ER-positive population. Maybe you can speak to that.
That was very nice. Yeah, I think we're all getting very excited about sacituzumab. Sassy for short. Sassy, because I wasn't sure it was sacituzumab. It's sacituzumab.
Govasitan.
Govasitan, which is a SN38 payload. So the active moiety of irinotecan, it's 7 molecules approximately of SN38 hooked up to each antibody against the antigen TROP2, which is very ubiquitous in triple negative and ER positive breast cancer. We don't even have to even screen for it. Patients were not selected for these trials, and they were a heavily pretreated group of patients, whether they be triple negative, and then as you said at ASCO, we heard about the ER positive, HER2 negative cohort, and the sacituzumab is given IV days 1 and 8 on a 21-day cycle, and it has myelosuppression as a major side effect, and some diarrhea, but less than we see certainly with irinotecan, fatigue, and some mild alopecia. But in a heavily pretreated population in the ER positive setting, the response rate was in the 30-35% range, similar to what we saw in a heavily pretreated triple negative population as well. And in the triple negative population, the median PFS was a surprising 8 months or something like that. In a triple negative, heavily pretreated population, that was really, really amazing. But the waterfall plots look terrific.
Yeah, so people sometimes refer to Kadcyla, TDM1, as a smart bomb. So here we've got perhaps the second antibody drug conjugate that may be closest to widespread use in breast cancer. Do you think it's smart, and also in terms of toxicity sparing? I've used irinotecan. Edith Perez published this paper years ago comparing weekly to Q3 weekly irinotecan, and it's a drug that I sometimes will use in the salvage setting. So to me, this certainly seems to be a kinder, gentler agent than using irinotecan.
That's my impression, Andy. I had a patient on 15 months on sacituzumab, very heavily pretreated woman, and I think that really is the key. I've used irinotecan too because it is really non-cross resistant, and always wished we could have a formulation of it or an FDA approval and get it on the NCCN guidelines, which it isn't at current. But the thing I think about the irinotecan is I find I keep dose reducing or spreading out the treatment intervals because of toxicity. It's just harder to get it in, particularly cumulatively, very, very fatiguing. So I think this has a better therapeutic index. I really do think so. Patients are benefiting. There's, obviously some people need dose reductions for myelosuppression in particular, but once you get them there, they can ride it. You know what I mean? And I think that's really the key. So I think it's similar to the TDM1, TDM1, yes.
That's a big word, atotrastuzumab.
Yes.
Are there any other drugs that you've got your eye on? Any other agents that you've got your eye on in the, well, it isn't necessarily the ER positive space, but for patients progressing on endocrine therapy?
Well, you and I are both very involved in the development of tezactaxel, which I think is a really interesting agent, and this novel oral taxane formulation, and I think that comes at a time that is good, because I'll tell you, I am increasingly reluctant to get to IV chemotherapy. It's like, oh no, there's got to be another oral agent. I find myself really digging deep to try to keep the women on oral agents these days.
So for that, 61-year-old woman who's had her 2.5 years on AI and CDK4/6 inhibitor, and then you played the fulvestrant card and the exemestane everolimus card, and now she's not only has 8 or 10 bone lesions, and she needs more than just acetaminophen and ibuprofen, and maybe she has a couple of pulmonary nodules, and you're ready to make that leap to chemotherapy. So where do you go next, and why?
I always go to capecitabine, and my definition of visceral crisis is getting more more severe, if you will, in terms of bringing out combination chemotherapy. Someone would have to have very rapidly proliferative, very heavy tumor burden disease, particularly in liver or lung, for me to bring out a combination with capecitabine. Of course, we use a taxane with
Didn't you study this regimen called docetaxel cape once upon a time?
I
And
did.
it led to an FDA approval.
Yes,
right?
yes.
So that's not what you go to
That's
first.
not-
You don't give
no.
dosi cape to that woman that I just described.
No, not to your not to your woman, but I have and I also like the vinorelbine because you don't get the hair loss, and I find that you can, for those patients with the most severe disease, I can even keep the doublet going, for patients, because if I do a doublet and I salvage somebody, then like, well, gee, were both drugs working, or can I stop the IV and keep going with cape? And I can't always do that, I have found, when I stop the IV. So I reluctantly, but sometimes you have to use a doublet. But otherwise, I go to capecitabine, and I've, learned how to, try to keep the dose intensity as high as you can. I try to use as many pills as I can in that 2-week period. You guys may use some 7 on, 7 off. Maybe you could update me what you're doing.
We prefer the regimen that Tiffany Traina developed in terms of 7 days on, 7 days off. Granted, there's no data from a randomized trial yet comparing it to 14 on and 7 off, but we do think it seems to be as effective, and you run into hand-foot syndrome and diarrhea, if at all, much later on. So
but you use a higher dose, don't you, Andy?
Yeah, for the average size woman, and I have to confess, I can't remember the last time I prescribed the 150 milligram tablet of capecitabine. But for the average size woman, I tend to start with 1,500 orally twice a day, and 7 on, 7 off. And for a larger looking woman, I'll give her 2,000, so 8, 4, 4, and 4.
In Tiffany's work, you guys did at Memorial, you could go up on the dose, couldn't you, in the 7 on, 7 off? You could. I think they got you up to, 8 or 9 pills a day or something like that, as I recall.
Right, so I try not to scare patients away early on.